Good morning. The talk is Mag-5. We named it, which Dr. Flowers named it Magnificent 5. It's upper and mid-face rejuvenation. Again, this was a technique invented by Dr. Flowers in Hawaii, and a couple of years ago we published that in Clinics in Plastic Surgery. And what is Mag-5? It addresses two areas on the face, basically upper and mid-face rejuvenation. So the first two components of Mag-5 focus on the eyebrows and the forehead. So it's essentially a brow lift, at the same time forehead rejuvenation, because removing the corrugators and smoothing out the forehead lines. And as we age, it's one of the first areas drop is the eyebrows. And I see in my practice many younger people, younger females or males, very droopy eyebrows, and especially in older population. And when they come for an upper eyelid surgery, they think that the problem is on the upper eyelid and asking for upper lid surgery. And almost 100% of those patients have brow ptosis, and to have a great result, they have to have the brow lift as well. Most choose and some don't, as long as they agree that I tell them, upper eyelid will fix 20–30% of the problem, because that's what it contributes. So it's a mechanism that you have to break the cycle. As the eyebrows go down, the vision is impaired. So in order for people to see, they constantly raise their eyebrows. When they constantly raise their eyebrows, then you have all these forehead lines. And by doing the brow lift and upper face rejuvenation, it fixes those areas. And the brow lift and corrugator removal, they are all done with the standard coronal brow lift approach. And in male patients, if they have male-type balding area here, you may bring the incision right there. It's essentially, it decreases this distance, but in females, literally the entire incision is within the hair, not at the hairline. And when they ask about if it increases the height of their forehead, even the high forehead people, it doesn't, because the way that I do it, or the way that I was taught by Flowers, is essentially a lateral brow lift, and you have a limited forehead in this area anyways. I pretty much don't move anything on the mid portion, so it doesn't affect. The next two components of the Mag-5 focus on the lower eyelid. So again, essentially it's a lower eyelid surgery, as well as canthopexy. Everybody gets a canthopexy. I know it's major, some may not agree, but I do the most major facial things. I do a facelift, as I mentioned, in the office under local. That's one procedure. I take patients to the operating room for general anesthesia, and if the patient comes and asking for isolated lower eyelid surgery, I just don't do it. I mean, it's 7 years, I haven't done a single lower eyelid alone. So either I have to do this or I don't. And with what happens on the lower eyelid also, as we age, when people complain about the excess skin and excess lower eyelid fats, baggy eyelids, the problem is not that they gain weight, and they gain some weight on their lower eyelids as well. The fat didn't get bigger. The fat has always been there, but as we age, when the septum relaxes, the skin relaxes, that fat starts bulging out because the septum is loose. So if that's the case, if the problem is not the fat, why do we have to go in and cut the fat out? So the problem is the septum, so you have to tighten the septum so it pushes the fat back. So you don't have these hollow eyelids, you have a beautiful full eyelids, and the problem is solved. What happens is the arcus marginalis, the border, gets quite visible because mid-cheek tissue migrate down, and the fat actually starts bulging out. So this area, tear trough deformity, becomes quite prominent. So to fix that problem, you fill this area by lifting the cheek and by tightening and giving the full eyelids. So it's like that. All these drawings actually belong to Dr. Flowers, and I'm going to show a lot of before and afters. They belong to me. If the hammock is loose, you don't just cut the hammock and sew it together. You tighten the rope. So it's the same concept with the eyelid as well. with this kind of eyelid, it's not removing the skin, it's the easiest part, but if you don't support it with the cantipexy, sooner or later you're going to start having either round eyes, too much sclera show, and some terrible ectropions that I've seen from some other physicians. So even, let's say, this kind of patient, especially in my town, there's an ophthalmologist does eyelid surgeries, and these patients get standard lower eyelid surgery, and they literally end up like this. So hollow eyes, ectropion, it's terrible. It's better not to do anything on these patients. So a little bit technical detail. So I first start the procedure with the lower subciliary incision. So afterwards, I create a skin flap. Literally, I separate the skin from the underlying orbicularis muscle. So it's a really thin skin, basically almost like a full thickness skin graft. So when you separate a couple of centimeters, you're looking at the orbicularis muscle, and then I incise partially, coming from lateral to maybe mid portion to mid pupil portion, the orbicularis muscle as well. So you're creating a skin flap and the muscle flap. And then and I go and staying on the lateral orbital rim and also the entire inferior orbital rim, release the arcus marginalis and release everything away so your eyelid becomes free. And I'm going to talk about the mid-cheek portion as well, but from the same incision, I do a complete subperiosteal elevation of the entire cheek tissue. So when I lift the cheek, literally I see the bone everywhere, including on the zygomatic arch. It's a safe area if you're right on top of the bone, and I lift everything up. So you have the entire cheek tissue up, elevated. You're just looking at the orbital rim, the bone completely, and then you have the skin and muscle flaps. So I put 3 drill holes on each side. So 2 of them is on the lateral orbital rim, which is used for the 2-layer cantipexy. One of the layer will be the lateral canthal ligament, and it goes through and through. It pulls it a little in and up. And the other will be, which I'll show you, the orbicularis muscle is also used as a 2nd-layer cantipexy. And I think it's the most powerful part of this procedure. By just taking that eyelid and just doing a cantipexy, and some other bands will be actually attached to the temporalis fascia as a very powerful tightening of the lower eyelid, as well as lifting the cheek as well. So this is basically showing the muscle flap is going to be attached. And again, in this drawing, it shows it's attached here, but at this point, after I dissect everything, I do the coronal incision. So when I lift up, I can literally connect my finger between the coronal incision to the lateral orbital rim. So I'm at the safe zone, everything is up. So after the drill holes, I literally take the edge, the lateral edge of the orbicularis muscle, and tuck it underneath and tie it with sutures, absorbable sutures to the temporalis fascia. So it's a very powerful lift there. And the last component is the mid-cheek lift that I mentioned. And with that's the area that I mentioned. This is a difficult area to fix if you're not doing an aggressive surgery there. Some may agree with the fat transfer, but I have seen some disastrous. I personally never do fat transfer on the eyelid itself, maybe below it at some points, because I've seen some really bad results, and you don't know how much of it is going to take, and if it takes a little bit more than you want, you have all these lumps, bumps, and they hate it. So I know Flowers designed the tear trough implants, and I've used that, but since I have been doing this technique, I almost never use those implants as well. This is one of the tear trough implants that Flowers designed, and again, this is showing the complete subperiosteal elevation of the cheek tissue and literally divide, and I can clearly see the infraorbital nerve vessels there, and you can safely dissect. And this is actually Flowers' patient, and with beautiful results. So the Mag-5 doesn't discriminate against age-sex race. So it's actually more younger patients, because after a certain age, 55, 60, or when they start having really loose skin, yes, they're going to benefit from Mag-5, but they're going to require facelift as well. But patients around 55 or younger, it's an ideal procedure when they start having these cheek trough, a little downward migration of the cheek tissue, eyebrows drop. It's a really good procedures for them. The only problem is recovery 2-3 weeks, they look really rough, and I tell them. So it's again a powerful procedure to fix the ectropion, and it's a beautiful way of fixing the ectropion with 2-layer camptopexy early post-op patient. This is flawless patient though, and he fixed that with the Mag-5 procedure. And I'm going to show some before and after of my patients, and this is one of the PAs who used to work in the ER. And this is actually 12 years later, because she used to work in Houston, and she showed up a while later. So, and again, the way that I'm proud, if you close any of these before pictures, if you just look at the after picture, you don't see that dramatic or pulled look, and they look, to my opinion, natural. This is actually my very first Mag-5 patient, as soon as, probably a few weeks after my fellowship training as the vice president of the hospital I was working at. So, and the patients ask about the experience, and I tell them that I learned from others' experience. So from day one, I do the exact same thing. So first or my last case, they pretty much look the same. And again, younger patients, it gives a lot more refreshed look. For males as well, from the tired look, and the more forehead lines are improved, and they usually have these angry look, and subconsciously they do it. And during that procedure, I literally remove these corrugator muscles, and I tell them that you will never have to have Botox at that area. You don't need that muscle. And few other patients, even though she has these round face here, since you are lifting everything vertically, and I tell them this is a true lift because there is no pull, you're literally lifting the cheek up, and after the procedure, literally they look like chipmunks. I mean, it's all the way here, it has to settle down. I know how they're going to look like. If I do it just right, and a few months later they may not have the result that I want, so I overdo it because I know it's going to settle down. The other thing that I forgot to mention, and some of those patients, at least 30-40% of the patients, I shortened the lower eyelid. I literally cut the lower eyelid 2-3 millimeter and put it back together. The problem is if the eyelid is too long, even if you take the lateral canthal ligament and put it to the bone, if this part is too long, you can only pull so much because the bone is the determining factor. So what are you going to do? If it's before the surgery, you have to diagnose it, of course. And I mean, if it's my plan, with the swelling, it's going to look tight during the surgery. So sometimes you say, maybe I shouldn't do it. And I've done it one time, I changed my plan, I regretted it, I had to do it afterwards. So if my before plan, the patient is going to need a lower eyelid shortening, I mean, it's kind of gross, but I literally cut the tarsal plate and put everything back together. It heals just right. This is one of my nurses. This is 5-year post-op. And this is one of the patients that she's a nurse as well, and she after massive weight loss after gastric bypass. And even though she has really high forehead, she looks a lot more refreshed. And what I did afterwards on her, I have to tell, I direct excision of her nasolabial folds as well. But this area filled very nicely. She looks refreshed. The patient, she had this angry look. She had some eyelid surgery by another physician. It's just everything is pulling down. So afterwards, she looks a lot more pleasant. Another patient looks probably the late 40s. And that's it. I have some of the details if you're interested in. I can provide the PDF format as well. Any questions?